Welcome to this episode of the BSR's Rheumatology Roundtable, where we will be delving into the brand new living guidelines for managing people with Behçets disease, which has been co-produced by the British Association of Dermatologists and the British Society for Rheumatology. I'm Ernest Choy. I'm Editor-in-Chief of Rheumatology Oxford, and it's my pleasure to be asking the panel to summarize the new guidelines. So in this discussion, we'll provide a very brief and succinct summary of what the key take-home messages are from the guideline to help clinicians to benefit from the guidelines. So without further ado, I want to go around and ask each of our esteemed panel members to introduce themselves to you.
I'm Steve Higgins. I'm the clinical psychologist at the London Behçets Centre of Excellence.
Welcome, Rob.
Hi, I'm Robert Moots. I'm a rheumatologist and I'm director of the Liverpool Centre of Excellence for Behçets.
Ruth.
Hi, I'm Ruth Murphy. I'm a dermatologist. I work at Sheffield in an MDT for Behçets disease.
Harry.
My name's Harry Petrushkin. I'm a consultant ophthalmologist and I work across Moorfields Eye Hospital and Great Ormond Street Hospital for Children. And I work quite closely with all the Behçets teams in London.
I'm Claire.
Hi everyone, I'm Clare Pain. I'm a paediatric rheumatologist at Alder Hey in Liverpool, and I'm the paediatric lead of the Liverpool National Centre of Excellence for Behçets.
So thank you and welcome all of you, and appreciate your time sharing your expertise with us. And you can see that we have a very diverse and broad panel, which represent the diversity of the guidelines and the multi-system nature of the disease. So perhaps I can start with Ruth. Ruth, could you start by giving us an overview of the guideline and why is it important and what does it include?
Yeah, I mean, the reason that we wanted to do these guidelines was because Behçets is a very rare disorder and it presents in many ways because of all the organs which can be affected. One of the problems with it is that people who live with the disorder and those caring for them, their issues are such that it is very, very difficult sometimes to meet all their needs throughout their life. About a fifth of patients with Behçets start in childhood. Many ladies affected will want to go on to have children. And we wanted a list of recommendations from evidence-based guidelines, which allowed us to give the most up-to-date and safest recommendation for the care of these patients. So that was where we sort of started from. Over a period of a couple of years, these guidelines were therefore published, and the shape that they take is a series of recommendations, some of which are general, stressing the need often for multidisciplinary team input to make a diagnosis because of the very many ways the disorder can present, explaining that because the disease is chronic but will have flares, it's very important when healthcare professionals see these patients that they assess for disease activity in all the relevant organs when people are assessed. We were very, very aware of living with such a rare and complicated disorder meant that the psychological impact for this group was particularly important, and therefore we gave emphasis to these patient needs. At the end of the whole process, it was evident that there were many more questions to answer, and therefore there were future research recommendations which were published. I think as well, the whole point of this is that it is an exciting area because there are many new drugs that are coming to market, some repurposed, some designed for Behçets. And so we very much wanted to make this a living guideline, and other people will talk about that as this interview progresses.
With that, perhaps I can move on to Robin and ask him, how was the guideline developed, and in particular, what makes this a living guideline?
Well, thanks, Ernest. It's taken many years actually to develop the guideline from start to publication, And the crucial thing, as with any guideline, it's got to be thorough, it's got to be robust. We wanted to make sure it's holistic and patient focused. So the first thing was to get together a multidisciplinary, multi-professional working group of experts. And this is the first joint guidelines that have been set up in collaboration between the British Association of Dermatology and the British Society of Rheumatology. So just getting all of that together, both of the groups are accredited for making guidelines. For example, BSR is NICE accredited, and to actually get harmonization of the two procedures took a little bit of time, but actually increases the robustness of the actual end product. So we're trying to make it holistic, patient focused, robust. It's accredited by NICE. And then the final thing is, in contrast to many of the other guidelines that people will be familiar with, this is a living guideline. And that basically means that individual recommendations can be updated as soon as new relevant evidence is available. So what we're not doing is waiting for some artificial arbitrary time when a new committee is being convened. We're constantly going to be reviewing what's going on, and if something is published that means we should be reconsidering things and potentially revising a recommendation, we should be able to do it much faster. So the idea is this is something that's living, it's going to be updated constantly. All of that's great, apart from those of us that are doing the regular updating. It makes our life a bit harder, but it makes your job much easier when you're actually looking for up-to-date relevant guidelines.
Claire, this guideline is unique in many ways, but one aspect is that it covers people of all ages. How does Behçets affect young people, and how is the guideline relevant to pediatric healthcare professionals?
Thanks, Ernest. So we ran a study a couple of years ago in the UK that showed that Behçets was extremely rare in children and young people under 16. Most had mucocutaneous disease, very similar to adults in the UK, but actually the brain, the neurological, ocular and vascular disease was less common in children and young people, but GI involvement was more common. We also found that over 80% of children and young people were being looked after by 3 or more specialties, and some of those up to 6. So it's fantastic to have this guideline that talks about developmentally appropriate multidisciplinary care, and also for the first time best practice around transition from paediatric to adult care for children and young people with Behçets. Because Behçets is so rare in children and young people, and those life-threatening and organ-threatening involvement, many specialist paediatric rheumatologists will not see that. So having recommendations that you can go to look for vascular, how to treat vascular involvement or neurological involvement that are evidence-based are really key to improve outcomes for children and young people. Also, as Ruth said, there's also recommendations for future research, and I'm really pleased to see that the unmet need for more research in paediatric Behçets has been highlighted, particularly the experiences of those living with Behçets, and also randomised controlled trials for paediatric Behçets.
Fantastic. So Ruth, Robert and Claire have all mentioned the importance of representation across multiple specialties in developing this guideline, because Behçets is a multi-system disorder. So I want to move on to Harry to ask him, how can the guideline support ophthalmologists to work with patients to manage eye complications associated with Behçets disease?
Thank you, Ernest. So Behçets, as everyone knows, affects the eyes as well as everywhere else. And the eye disease, much like neuro-Behçets and large vessel involvement Behçets, can lead to irreversible damage. So unlike the part of Behçets, say with mucocutaneous disease that relapses and remits and you have a chance to intervene, with Behçets, if you have a nasty eye flare, then you can irreversibly lose vision. And the study from the 80s that people cite when they talk about how bad it can be was that 90% of patients lost vision in both eyes within 4 years with no treatment. Now, fortunately, in my working lifetime, that's not our reality, and I reassure patients that that's not something we see ever, really, anymore. But it really can be quite devastating. And so the importance of knowing when the ophthalmologist needs to treat straight away and doesn't have time to involve other specialties for a holistic management plan, and times where actually you can say, well, this is severe, but we can start treatment, but it's really important we get an underlying diagnosis. One of the concerns of the past was when you treated too aggressively when patients first presented, the rest of the Behçets then went away, and effectively you had this silent trail of all of the previous manifestations. So a really good multidisciplinary clinic is completely essential, but you also need to be looked after by ophthalmologists that know Behçets and understand when you need to urgently step in. And so this guideline is really clear on that. It tells ophthalmologists, if you have a sight-threatening manifestation, you need to treat in this way, and you therefore don't wait for a MDT response. Whereas if you have, say, some milder ophthalmic manifestation, then you've got the time for that.
Wonderful. So Ruth, right at the beginning, mentioned that Behçets disease has a significant impact on the individual's mental well-being. So I want to turn to Steve to ask him what sort of impact did yourself and other clinical psychologists in the working group have on the guideline development?
Yeah, I think when we came together as a group, I mean, first of all, I think, you know, the biggest impact we can have is actually to be in the document. All right, and it's sorely obvious, I know, but the history of that is embedded within the centres of excellence. So that psychology was always a planned part of the service, rather than an afterthought. So we're in the guidelines, and it's pretty comprehensive. We're given enough space, so that's great. So we're here and on the map. When we did the review, I guess two areas kind of jumped out at us for the lack of evidence. One was service models, and I think that's really important in terms of impact. And the other for us was the specific psychological therapies that we were offering or could potentially offer people. Because there's so few of us in such a small rare service, we have to use what's already there, what people are already using. So it's tapping into the existing mental health and psychology services that are around the country, rather than trying to reinvent a comprehensive service ourselves. So we built in the guideline a service model kind of idea that really shifts the idea of mental well-being, psychological concerns from a box that says psychology to actually much more refined, multi-level kind of needs for support and multi-level roles for everybody in the team. And I think that fits with the MDT ethos. And we adopted a model that mimicked quite similarly to mental health models, the kind of stepped care approach. That's really helpful for us because we think that helps communication liaison with these types of services, which can often be problematic. And they could understand the language we're talking, and we can fit into the services better. We could also cut across the services because mental health services and psychological therapies are subdivided into different areas. And it's generally different departments and sometimes different NHS trusts that offer those services to patients from one locality. So it helps to bring that together, and that's really important in the experience of people with Behçets, is to have ease of access, a fluid multi-level support, rather than these kind of maybe slightly outdated ideas of people simply having depression or anxiety and kind of siloed ideas. So it helps to broaden that experience, the psychological experience. I think the other thing it offers is flexibility in that model, because you can move up and down it. So again, it helps facilitate the patient through the process. In terms of therapy, there's very little that's directly related to Behçets, which is not a surprise given its rarity and the amount of psychological interest that's been invested in it. But we did come up with some ideas, and I think this is this is going to be the area of the guideline that we will develop much further. And there's a couple of cautions here as well if I say this. We generally adapt from other related areas, and we've listed the most common therapies that we use, like cognitive behavior therapy, third wave therapies like acceptance and commitment therapy, mindfulness and compassion focus, and various others. The two things that have made the most major impact on the well-being for people, the psychological well-being for people with Behçets. Number one is the change and reduction in symptom to diagnosis. That is absolutely crucial in reducing experience and build-up of trauma through people's lives. Okay, so it renders it more amenable to treatment if it's caught earlier, if it's worked with earlier. And I guess the second area, which costs no money at all, and is the medical trauma area, is how we as professionals traumatize our patients when we have consultations with them. And I think that's something we should all be thinking about. And everyone, all professionals across the board, need to think about that, because it's pretty ubiquitous within the population. So these are things we can work on and highlight that I think would make actually a really big effect.
Great. So we've heard that Behçets is a rare but very complex and severe disease that require multidisciplinary expert care. And so we need a living guideline to address this complex issue, which is also fast moving in terms of having new treatment for the condition. But I want to come back to Rob and ask him, how would this guideline help clinicians in primary care to manage or identify individuals with Behçets disease?
Yeah, I mean, Behçets, what a crazy disease. Few people can pronounce it and even fewer understand it. So if you're watching this podcast in primary care, I'm really pleased. We're really pleased that you are, because we really want you to be able to understand more about this. Some people wrongly think it's almost impossible to have Behçets in the UK. I can tell you we've got 700 patients just in the Liverpool Centre. So there are more patients around. And if nothing, I'd like these guidelines to be raising awareness, because the clever thing is thinking of Behçets. For the likes of us, we've all got loads of people with Behçets. It's you in primary care, in other specialties, who sees a patient, thinks of the diagnosis, and then be aware of the sorts of things that can be done, the specialists around that can help you, because that's really the crucial thing. And within the guidelines, there's plenty of advice about relatively easy and straightforward ways to manage symptoms. Ulcers in the mouth, skin problems, genital ulcers. So all of those things don't really need high cost fancy drugs. Just by thinking of the disease, just by being aware and providing simple treatments, that can provide a lot of help to patients. Furthermore, we've really emphasised the importance of having an appropriate expert multidisciplinary team. So not everybody with Behçets needs to be seen in a major centre, but everybody with Behçets needs to have an appropriately trained specialist who can be taking care of them overall. And certainly in the centres, we're very keen to be liaising with patients' primary care teams, because it makes far more sense to us for patients to be cared for nearer home rather than travelling up to hundreds of miles to see somebody somewhere else. So for all of these reasons, I want you to know that primary care is really important, and that we do hope that the guidelines will be helpful to you as you're looking after your patients, because there'll be more of them than you can ever imagine.
Thank you. Ruth, what do you think the impact of this guideline will be on people with Behçets?
Well, as both Steve and Rob have said, there are a couple of themes which commonly recur when we speak to our patients. I think probably the commonest one is that people will say, why has it taken so long to diagnose me? And that is because it's actually a very difficult diagnosis to make. And we emphasize that in this guideline. There isn't a blood test, there isn't a genetic test. We're looking for a constellation of clinical features which accrue over time. And as Rob has said, many of them will be mouth ulcers, genital ulcers, skin lesions. But as Harry said, some of the presentations can be more severe and and potentially lead to permanent damage if the eye is affected by occlusion of a vessel or inflammation of a vessel, which helps with vision. So those sorts of things mean that for the patient trying to navigate through what type of Behçets they've got, will they go from a low grade but troublesome version, maybe a mucocutaneous type, or will they escalate to something which could cause permanent damage to something vital like the eye, produces a lot of anxiety. And we hope that these guidelines actually make it clear that we're trying to help the whole of the healthcare workforce understand more about this disorder. As Rob said, raise awareness generally. Patients hopefully will know that we are taking their concerns seriously, so we don't get trauma and stress because of delayed diagnosis, not because people have missed the diagnosis, that can sometimes happen, but just because sometimes in the lower grade presentations of the disease, which really, these forms of the disease also have massive impact on our patients, but it can take a long time to reach diagnostic certainty. And so we hope that the guidelines will reassure patients that we are taking them seriously by helping them and the people that look after them understand more about their condition, understand their need to understand that the problem does flare and settle. And so, sometimes when they've waited for an appointment, there won't be any symptoms to see. Understand that we need to evaluate their disorder when it flares, but also throughout our follow-up consultations to determine whether there is still some low-grade activity and maybe the medication needs to be fine-tuned. And to help all those diagnostic and management decisions, we actually do have an algorithm which is quite detailed in the guideline, and I'm hoping that the patients will see it. They have a plain language summary to explain the guidelines, and they also can show that to the people looking after them, primary care, secondary care, make them aware of the guidelines, and hopefully they'll be reassured that in this way we're trying to optimise their care.
Thank you for that wonderful summary, Ruth. And I want to thank all the panelists today for summarising what the new living guideline for Behçets highlighted and how it will contribute to improving the diagnosis and management of this very rare but very significant disease. Those of you who will have a chance to read the guideline will recognize the enormous amount of work that has gone into developing the guideline and the literature that covers, but they're also very succinct algorithm and summary that will help you to manage patients with Behçets disease. The guidelines will be published by Rheumatology Oxford, but also the British Journal of Dermatology, and they will be available at the association's websites. Thank you very much, everybody, and goodbye.